Everybody, Dr. Rob Silverman here. I am with Metabolic Health Superstar, OBGYN specialist, Dr. Charles Cavo. Dr. Cavo, I really appreciate you taking time out of your busy day to come join us. How are you doing today?
Dr. Rob, I'm doing great. Thanks a lot for having me on the podcast. Looking forward to it. A little bit nervous because, like you said, I don't do this very often, but given the invitation, I was all in. Sounded like a great opportunity.
Well, I'm sure you're going to flash past any expectation that you have. You're going to give a lot of information. I'm comfortable. So let's get in. Ozempic. Oh my God. Everybody's taking Ozempic. Everybody wants to take Ozempic. From the 400-pound person on 10 medications to the 210-pound person, Ozempic. So I'm opening up Pandora's box. It's all about you. You know,
Wow, right out of the gate, we're gonna hit the GLP drugs. That's
that's right. GLP-1 receptor agonist. Let's go.
That's great. So we have a metabolic center here in Connecticut, and we used to practice one way, and then the drugs hit the street when it came to GLP. The efficacy, the benefits, and the calls started pouring in with regards to can I be on these drugs or should I not be on them? And I don't know if you're going to like my answer or not, but I actually love these drugs. They're fantastic for the patients, for the practice, for improving metabolic mayhem that people have. However, they definitely come with a bit of a background where you have to really have somebody working on lifestyle and some sort of sustainable process to make these drugs legitimately worthwhile, taking on the side effects, the risks, and the cost for a lot of people. Otherwise, you're basically putting a Band-Aid on a problem that we've been trying to deal with for a long, long time.
Well, docs like you, I had a meeting with 3 or 4 of my friends that are really excellent, eclectic, integrated doctors like yourself, highly trained, Ivy League, the whole bit. You guys got the resume without question. And I have found in life, especially in healthcare, that you have to talk to others and you have to talk to the other side, if you will. So, of course, my back hairs of chiropractic origin said Ozempic drug. Now, of course, I'm wrong. And I readily admit that because I asked them in my conscious, my mentor got up and said, do you treat people that weigh 400 pounds that are taking 10 medical drugs, many of which are blood sugar, cholesterol, etc.? The answer to that question is no. Most functional medicine people do not. It's more like 275 looking to lose 50 or 75 and turn their life around, not where they may turn around, hit the door, and pass away. So we came to an accord, and I agree with you. And I think what you said, which was great, is that you're going to help them with lifestyle, because my understanding of Ozempic is 50% of people stop it after 12 weeks. So question number one is, once you're on it, do you have to stay on it? And if so, okay. But if once you're on it and you're supposed to stay on it and you don't, what happens?
So we get that question a lot before we start the medication and then while we're using the medication. And there's not a one size fits all. So I would say that people that start Ozempic, Mounjaro, Zepbound, Wegovy, those people are not buying a ticket to stay on the drug forever. There's no doubt about that. They are buying a ticket for some momentum with regards to a problem that they have with their metabolic picture, and will have something available that's going to facilitate weight loss. A lot of times people will have a goal in mind with regards to where they want to get to with their body composition, with their health, or with their weight. And so once they reach that goal, and let's say they did it by the use of the medication as well as their lifestyle changes, what we'll typically do in the practice is we'll add in some supplements like allulose or exogenous ketones. We could talk about that later on if you want to. And we'll start to also space out the dose of which they're taking their medication. So if it's every once a week dose of the medication, we'll move that dose to once every 14 days and add in the supplements that also have a GLP effect, and monitor those people closely with body composition scales in the offices to see what happens when we start to space the dose out, and then what happens if we start to decrease the dose. Now, for our patients, a lot of them have made appropriate lifestyle changes. They've journaled along the way. They understand that there's now a calorie deficit that they've been enduring because of the side effects of the medications, or they've been able to carve out the cravings from the medications. And so they're aware that changes did happen with regards to what they were eating, and they can leverage what they learned about themselves as they start to decrease the medications. There are other people that may not have done that kind of homework, or maybe there is a different metabolic function that the medications played, in which case those people, it's a little bit harder to justify dialing back the medications. They might be on it for a longer term. So that's kind of what I would say about, are these medications forever once you start them? I would say no to that, with some caveats that there are people that are going to be using them for a very long time. Since they haven't been out for a lifespan of people yet, it's hard to say, is it forever? But there certainly are people that we think we can stop the drugs and we start to space out the medication doses. And lo and behold, you see the body comp change very quickly, in which case we start the doses that were working right off the bat again.
So it's been stated that a third of the weight loss on the way down, obviously weight loss, has been attributed to muscle mass, which is really not what we want to lose in the longevity scheme. Then the rebound, which is the concern when you go off it, the rebound is a loss of, or a regaining of, well, I should say correctly, a loss of 40% of muscle mass. So those numbers really bear the idea that the bulk of the loss in Ozempic is muscle mass and not necessarily fat. Can you speak to that? Can you say how to avoid that? And then I'm going to couple it. I'm making a mistake. I'm asking two questions at one time. Can you tell everybody the difference between Ozempic, Mounjaro, and Wegovy, semaglutide? Because I think they all think they're the same.
No, they're different. But let's talk first about the muscle mass concerns that people have. In our practice, we use these medications frequently. I have not taken a person off the medication because of concerns with regards to loss of muscle mass. I know what the literature says with regards to the 1/3, 2/3 that you just cited. However, I think that if a person is using the medications under the supervision of somebody that understands metabolic dysfunction, appropriate protein needs, requires resistance training or exercise coupled with the medications, I just don't think that you're going to see the body wanting to, in those instances, lose the most important organ, muscle, when it's got plenty of fat to burn. And so I think that, sure, there is a concern that we all have when we start using these medications, especially in patients that might be prone to skeletal muscle loss, like perimenopausal women or menopausal women. However, if you're giving the right kind of protein, the right amount of protein, advising on the right kind of exercise and resistance training, I think that the amount of skeletal muscle mass will not drift nearly as much as what people are concerned about. And then with regards to the question on, are these medications all the same? No. There's a GLP drug, which is the Wegovy and the Ozempic. And then there's GLP plus. That plus is an extra hormone, GIP, or an extra peptide. So there's GLP and there's GLP plus GIP. So the GLP GIP is Mounjaro and Zepbound. And the GLP drugs are Ozempic and Wegovy. The differences between those medications is actually kind of interesting, where the Zepbound and the Mounjaro, which is the GLP plus, those drugs seem to be much more tolerated by patients when you're talking about side effects, nausea, feeling reflux, and GI upset. Whereas the drugs Ozempic and Wegovy, they can sometimes have more side effects with patients. That being said, again, I very rarely will choose one over the other because I'm expecting improved side effects or tolerance of the medications. I know what the literature says, that one is better tolerated than the other, or one sees more weight loss than the other. Honestly, the way we prescribe the medications, I'm kind of embarrassed to say this, but a lot of it boils down to, what is your insurance going to cover? And how am I going to code for the drug because they're so expensive and challenging to get. And so if a patient doesn't have diabetes and we're just using the drug for obesity or for abnormal weight gain, Wegovy and Zepbound are the ones that are approved for those indications, and we'll see if the insurance is going to take one over the other, and we'll go for it. If somebody experiences the side effects and can't handle the medications, sometimes we'll choose a medication like Zofran or an antiemetic or a proton pump inhibitor like omeprazole or something to sort of sidestep the side effects from the medications and allow us to continue to leverage those medications and titrate them appropriate to see a good response.
Now, CNN with Sanjay Gupta, who I have a large amount of respect for, did a special on Ozempic. And what he said was, or essentially, here's the highlights. Obesity plays a role in over 1,000 genes in your body. Obesity is a disease of the brain. Ozempic actually diminishes the food chatter in the brain. It actually sends post-nutrient hormones to the gut, the brain, and the pancreas, which is allowing for satiety or pre-ingestion satiety. It kind of disrupts the brain's reward center, which we all in America have lit up because of 160 pounds of sugar per year, et cetera, ultra-processed food. We don't want to go down that rabbit hole. Can you be a little bit more specific to what is going on with this GLP-1 and the part of the brain that it functions with?
So with regards to, can I be more specific? I'm not a neuroscientist or anything like that, but I have read enough and heard enough to understand that those medications are acting centrally in the antiemetic center of the brain, and the GLP plus drugs, so the Mounjaro and Zepbound, are going to hit neurons that are responsible for reducing the nausea that you feel when you increase your GLP, which is the Wegovy and the Ozempic. I also know that there's been some pretty new, interesting research that's come out, and I definitely would lean into this also when considering these medications and the advantages that they have. With regards to the reduction of the risk of dementia and Alzheimer's and the role it plays with decreasing uric acid and decreasing the metabolic dysfunction that happens centrally at the level of the mitochondria in the brain when you're using these medications. And so I think there's another role that these medications play outside of just let's try to get ripped abs and go to the beach and look good on these medications. The metabolic implications and the reduction of chronic conditions that are so much involved with handicapping our medical system and what we can afford is, I think we're just at the beginning of understanding the true benefits of these medications. And for people that, and I hear this also frequently in my practice, for people thinking that these medications are a cheat, or they're cheating, their willpower and they don't need them. I think those people need to try to reprogram their thought process behind the medications, because there's not a cheat. When somebody is abnormally gaining weight and can't control their weight and suffers from elevated BMI, obesity, what have you, and you're offered what should have been in place many years ago, a metabolic resolution to the problem that we've often mistaken for a behavioral situation, when in fact mainstream, right down the middle of the lane for obesity, is endocrine peptide hormonal dysregulation. These drugs are offering answers to that we haven't really seen for many, many years, if not ever, when you approach somebody that's suffering from abnormal weight gain. And you're seeing all these other incredible health benefits: improvement of blood sugar,
right?
Reduction of Alzheimer's, like I just mentioned, reduction of uric acid, which has its own sort of risks, and so many other sort of benefits from the medications. I can't fathom why people look at these drugs as a cheat when it comes to an actual cure and something that we're all looking for, which is preventative medicine.
So I don't think of them as a cheat. I think they have their place. And what I love about the podcast is, and one of the things I always promised myself was, I didn't always have to put people on that we had to totally agree. We should have the conversation because you saw how I moved when we had the conversation. So I'm going to try and move you a little bit. I don't build my podcast like some other guys and have everybody fight and see who can do more push-ups. You know, that's in the rearview mirror. So I'm going to give you some natural ways to activate the GLP-1, and you tell me how you feel about it. And, you know, again, we're not comparing one to the other. We're saying for a natural approach for somebody who is not in a medical emergency, if they would adhere to the program, would you be comfortable with that? And would you also use this in alignment with what you do? So let's do it. Berberine.
I use it all the time. I think it's great.
Ginseng.
I haven't used it. I've read the data. I would use it if I had it. I don't tell anybody that it's not efficacious.
Green tea extract.
Don't know what that is. Well, did you see green tea? Oh yeah. So green tea extract, we use that and think that works very well.
Probiotic strains, the Akkermansia. Ooh, the panacea for blood glucose.
All the time. I love that stuff. One of my favorites.
Excellent. Fiber, psyllium, of course. Omega-3 fatty acids.
100% on board with all of that.
Eat more protein, approximately a gram per pound of body weight.
Stabilize the blood sugar, bring down the insulin, increase your GLP. Love that.
Magnesium, more of a magnesium glycinate or a glycine and a lysine, not the citrate for the poop effect.
Yeah, everybody seems to be mag deficient that we see. We always start magnesium. Think it's great.
Glutamine.
I love glutamine at the level of the gut for people with gut problems.
And speaking to my Joe, caffeine.
Yeah, I mean, caffeine seems to be a drug of all uses. I definitely do not have a problem with that. And as far as us being on the same side of the street or different side of the streets when it comes to the pharmaceuticals and the GLPs, I am definitely not a pharmaceutical loving kind of physician. I love de-prescribing medicines much more than I like prescribing medicines. And a person that comes into our practice asking for the drugs on the first visit, they definitely are not in the right practice. If we could get a person to use some of those supplements that you just mentioned, as well as some of the others, to get a natural endogenous production of their own GLP, which we do all the time, that is our preference. When we can't, and we feel that we might lose a patient who's going to increase their risk for being sicker because we just dug our heels into the ground and they want to use all the tools in our toolbox, I think that's kind of foolish medicine. And so we'll use them, but it definitely should not be the first line sort of treatment that is used when approaching a person with metabolic dysfunction that's causing abnormal weight gain.
We are on the same side of the fence because we have everything in front of us. We pick and choose what's best for the patient. And that's why it was so compelling to get you on. Because your body already has a built-in weight loss system. If functioning well and if the patient's compliant, that works like Wegovy, Ozempic, and Mounjaro. It's food in your gut microbiome. But you mentioned something before, allulose. I'm going to give you it. Here we go.
Yeah, I love allulose. I use RX sugar on just about all my patients. Anybody that is willing to hear me out on my pedestal with regards to, or on my podium with regards to what allulose is and the benefits of using RX sugar, which is all about allulose, is definitely important. Allulose is a natural sugar, and it functions though differently than sugar does in that it does not increase insulin like regular sugar or fructose or sucrose, but it actually decreases insulin. And it also increases the production of GLP, which causes a reduction in appetite and satiety. The trick with allulose, I think, with patients when we use RX sugar, and that really is the only allulose that I'm familiar with, is helping them understand that even though a person might not be eating sugar, and I don't assume everybody eats sugar that comes in to see us, and usually most people don't eat sugar. I want them to in the case of allulose and RX sugar. I prescribe it to patients that wake up in the morning and have an elevated insulin. I don't want them on medications first and foremost. I want them on allulose, a natural sugar, because the research is showing over and over again that 10 to 20 grams of allulose in the morning. So you can pour it down your pipe, you can take it in a syrup, you can use it as a like a pop rock candy. If you use that, you're bringing your insulin down and you're bringing your GLP up naturally. You can't really beat that as far as health goes. And I'm not doing it because I want to create a sugar addict in my office. I'm doing it because I want to take care of the metabolic problem that they have, and I can do it with a natural sugar. So the effects of allulose last for anywhere between, say, 3 to 6 hours before that effect starts to wear off, in which case, in certain circumstances, I want to dose them again. So I will use around the clock dosing of 10 to 20 grams of allulose throughout the day, which really decreases a person's appetite and cravings when it comes to overeating. You get a very similar effect that you would if you just took a dose of the Ozempic once a week. The difference is simply how quickly you're losing the effects on the receptor of the GLP from an enzyme that breaks it down when you use allulose as opposed to a GLP agonist. You're using a real GLP in the case of allulose, and so the effect is going to be gone quickly. Whereas with the medications, it's taking a lot longer to break down that GLP agonist that's sitting on the receptor. It doesn't work for everybody, the allulose trick, but I will say that for the majority of the patients, when you're talking about such a low cost to get such a big effect, it's a no-brainer. I love that trick when it comes to endogenous or getting a person to make their own a GLP rather than reaching for the syringe.
You know, I got some information on allulose. It's interesting because I'm a big proponent of stimulating the vagus nerve. So oral allulose does, in fact, as you said, induce the GLP-1 stimulation. It does so in the portal vein several times over. It actually stimulates the vagus nerve or the vagus nerve afferents by this GLP-1, leading to reduced appetite and improved glucose tolerance. The vagus nerve, the communication between the gut and the brain. So most people don't realize these GLP-1 receptor sites. They're actually in the Leydig cells, the L cells in the gut, and they communicate with the dorsal medial portion of the hypothalamus, the part of the brain that is not encased by the blood-brain barrier. So, okay, now we nerded out. What does that mean? The gut communicates with a part of your brain that is unprotected because it's supposed to be able to communicate properly. In our modern day, the problem is the GLP-1s are not communicating with that part of the brain, and everybody thinks they're hungry. If you take allulose, if you take Ozempic, if you take those natural supplements, if you use laser light on your hypothalamus, you now have what we call pre-ingestion satiety, and you're not going to run to eat massive amounts of foods. And that's essentially the Reader's Digestion version of what is going on. Now that you segued, we started out with the big O, Ozempic, but you're doing something fabulous in the Dominican Republic on metabolic recovery. I'd love to hear more about that. I know my followers would as well.
So this is a kind of a new project that was introduced to me. So I don't know 100% the ins and outs of it, but I'll do my best to sort of share with what's been presented. And that is a metabolic health resort, which is being built and I believe will be open the goal is to have it open in 2026. And at the metabolic resort, the goal of the people that are building the resort, Renovate Recovery, they would like to bring into the resort people that have metabolic dysfunction or might be post-op from different types of surgeries like heart surgery, patients that are suffering and rehabilitating from myocardial infarction, stroke, diabetes, these kind of things. And the premise of Renovate Recovery is to offer them a very healthy environment with no other choices but to be healthy when it comes to nutrition, lifestyle, exercise, these kind of things. So it's going to be a go-to place for people that are on the road to recovery and don't want to be distracted by what's at every corner that you turn to, processed and ultra processed foods, right? So that's what Renovate Recovery will be. And I'm very excited to be part of that project as an advisor with regards to the types of nutrition that they're going to be offering.
Now, your background is in OBGYN, am I correct?
That's correct. Yes, I'm a boarded OBGYN.
So let's get to the big thing. We had the queen of hormones on a couple of weeks ago, Carrie Jones. She was double thumbs up for HRT with women. It's a question I get asked all the time. We could talk about it every week. What's your feeling on women going through menopausal transition and HRT therapy?
I would give it double, quadruple thumbs up when it comes to hormonal replacement therapy for women. I think as a practitioner who trained while the Women's Health Initiative was coming out back in early 2000, which was a study that sort of set a stage for some concerns with regards to hormone replacement therapy and had a lot of OBGYNs throttling down on recommending hormone replacement therapy, set the stage for well over a decade of inappropriate, I think, guidance when it comes to using HRT in women that are suffering from symptoms associated with menopause, which could be depression, insomnia, hot flashes, libido, you name it. There's a litany of like different conditions that women suffer from that can be resolved with hormone replacement therapy. And I think in the current sort of environment, many OBGYNs are now getting over the bar of what was or the obstacle from Women's Health Initiative, becoming more and more comfortable that hormone replacement therapy is beneficial when people are suffering from these kind of symptoms of menopause. In addition to resolving those symptoms, you can't argue that it reduces the risk of diabetes, it reduces the risk of dementia, it reduces the risk of depression, improves relationships. There are so many benefits when it comes to HRT that I just don't know how you could argue against it if a person's experiencing symptoms and again, you have a tool in the toolbox that you could use without much of serious risks. Certainly not breast cancer.
Well, that's the big question. Women want to do it. They're scared the bejeevers of HRT. Wasn't there just one article many years ago that's been dispelled?
I think there have been many articles with regards to the numbers and the use of hormone replacement therapy and the correlation of breast cancer and HRT users, that it just has really painted a picture of risk when there really isn't risk. It's sort of like on par with saturated fats and heart disease, right? I mean, I've listened to your podcast now enough to know what you're going to say when I say saturated fats don't really cause heart disease, right? Yeah. So I think that is sort of synonymous with HRT does not cause breast cancer. So I think that unfortunately, the damage has been done by the papers and the studies that were out there with some misguided numbers or not accurate deciphering of the numbers to truly understand risks that were associated. And now you're left with many people being scared of where the truth is. And you just have to spend time talking to the patients and understanding what their fears might be. And at the end of the day, if you can dispel the fears and underscore the benefits of the medications or the hormone replacement, then everybody wins. But it takes time and listening and educating to sort of get over the obstacles that we now have in front of us. But I am a big fan of hormone replacement therapy. And I think withholding them when a person is suffering is really problematic.
So we're at that part of the podcast, since you watched a few, where we do a little bit of a rapid fire. So I'll ask you something and we'll look for a concise answer. Not, you could do anywhere from one word to whatever you feel comfortable, but this one's not going to be a dissertation. So let's go. You ready? You strapped in? Here we are.
I think so. Hold on, ready.
Ketone bodies.
Ketone bodies, I like having them around. We test them with a device called Keto Air. It's a new device that's out. It's a breath test where you blow into a device to see if you're in ketosis, if you're on a ketogenic diet. We certainly like having those around if you're on a ketogenic diet and want some information.
Well, we know how you feel about hormone replacement. How about testosterone replacement for men?
So because I'm an OBGYN and my training was really for women, I can speak a little bit more to testosterone replacement for women. But when it comes to testosterone replacement for men, I am a big fan of that type of therapy. I don't personally do it myself. I refer those patients out to some of the local urologists and endocrinologists after I diagnose it in men. And when they get the TRT, it's like the lights go on and they love it. And I love the results from it. So I think it's great.
You're motivating me. You're motivating me. 3 best supplements for women's health.
3 best supplements for women's health. I'm going to have to say magnesium. I'm going to say the probiotic Akkermansia.
Okay.
And I think the third one might surprise you, but I would say creatine, about 3 grams a day.
Love it.
Yeah, I like that supplement a lot for both men and women, but specifically for women, especially for perimenopausal, menopausal, for maintenance of skeletal muscle mass and reducing the risk for osteopenia, osteoporosis.
That's funny.
And,
you took a bit of my thunder. I was going to ask you about the 3 supplements for the menopausal transition female.
No, there you go. There's 2 of them, the magnesium and the creatine. And then the third one, I would just always add in protein. I think we're always looking around for protein, and an answer for protein comes in the form of whey. We use Naked Whey products here. Sure, there are plenty of different brands out there that are really good, but yeah, whey protein, it's just a no-brainer when it comes to getting at least an extra 25, 30 grams of protein into a person that's always in need.
Hot flashes, night sweats. Help me out.
Yeah, there's not really any supplements out there that I've come across that are going to work. There's some that might have a placebo effect, and I love placebo effects. But at the end of the day, if you're drawing blanks on all the supplements that have been thrown at you and you're still suffering from hot flashes, insomnia, then I would get a physician that's going to prescribe an estrogen patch or an estrogen pill. If you have a uterus, you're going to be needing some progesterone along with that. But that's how I would handle those kind of situations.
Needed supplements during pregnancy.
Well, you're going to need a prenatal vitamin with the folic acid for pregnancy. And then the supplements for pregnancy, I think, again, magnesium goes a long way. Vitamin D can certainly be helpful when it comes to pregnancy. Fiber, just because the incidence of constipation becomes problematic and can certainly be avoided. Hydration. So I don't know if water is a supplement or not, but I don't think anybody drinks enough of it. Certainly when they're pregnant, you lose a lot of water, and you certainly could put water in your mouth and avoid certain problems that crop up.
Myth or truth? How's this sound?
All right.
Tylenol has an adverse effect on the child if the mom takes it for 1 or 2 days. I got asked at a seminar. A woman basically said that there were studies that told her, I won't say how I feel about it, that if she took Tylenol, it increased the incidence of autism.
Yeah, I'm going to say myth on that one. I did not see any studies to support anything of that sort when I was doing OB.
Black cohosh. Why does everyone talk about this? For women, of course.
I think it came up on the radar, maybe like resveratrol did or something of the sort. I mean, maybe it works, maybe it doesn't work. There's certain people that certainly have experienced resolution of their symptoms from menopause by taking black and cohosh, but I haven't seen it enough times or heard people use it who became asymptomatic to think that it's something that I want to recommend to my patients that are experiencing side effects of menopause.
These menopausal metabolic changes that lead to insulin resistance and weight gain, why is that occurring? And other than Ozempic and the GLP-1s, not that there's anything wrong with them, how do you guide them through it and how do you individualize and personalize their health journey?
So I'm not sure if there's an accurate answer for that question because there's so much that's going on with the hormonal changes during the phases of menopause. However, I would say that it would be hard to argue that the muscle fibers are not playing a role with regards to the disposal of insulin and glucose as women transition from perimenopause to menopause. And that change in muscle fiber causes, I would say, an increase in the amount of time a person's exposed to insulin. And that increased time of exposure can cause central adiposity or weight gain in the midsection. So I think that there is probably a correlation, although maybe not totally understood, that spells out this starts with muscle fiber changes that occur from a reduction of hormones as a person transitions through menopause. Can that be prevented? Yes, diet and exercise certainly can help, but you can't change your diet to beat the changes in hormone. And so I think, again, that's where hormone replacement comes into play, resistance exercise comes into play, advising patients appropriately on the amount of protein they could use, the benefits of creatine, maybe even testosterone replacement or a supplement like DHEA to bump up testosterone levels that also start to go down as women transition. So I think it's the muscle fibers that you could more directly put crosshairs on with changing a result when it comes to menopause and that central sort of gut that they experience. Obviously, like you said, supplements that increase GLP or drugs that are GLP agonists are also really advantageous in these kind of situations.
I love that answer. I love it. I love the idea that you individualize it and help them. It's a journey. So it almost feels, I feel this evocative view of you holding on to the patient and you walking them through the journey. It's great. I mean,
Yeah, I just had a patient, we see our patients for years and years here. And, this one patient, I just saw her today, started with her practice at 43. And today I saw her, she had just turned 51. But her changes started in her mid 40s when we first started seeing her. She came to us because she had been able to control her weight all along. And then all of a sudden something happened at 43, 44, and her weight started to go up. She wasn't having symptoms that were outrageously yelling, this is menopause. And everybody is telling her, well, let's just watch and wait and go eat less and exercise more. And that's just bad advice. If you get the advice to eat less and exercise more after complaining about, being able to control your weight and now you can't, even though nothing's changed, definitely look for a different direction when it comes to the healthcare provider that gave you that advice. So in any case, as we handheld your term, this patient through that transition, and then she finally was diagnosed with menopause, the one day of the year that she can say my last period was 365 days ago. That gave her the diagnosis, which is like a problem right there, right? I mean, the transition is years and years, but as we handheld her through that, we were able to individualize or personalize what we were recommending all along the way with regards to oral contraceptive therapy. So OCPs work really well in some of the symptoms that she experienced without having her go off the cliff of no estrogen. And then dialing those down because of some side effects, and dialing up the use of exogenous ketones, akkermansia, allulose, and dietary changes, along with the right kind of proteins and the right kind of ways to exercise, and then dialing those in so they become sustainable and lifestyle changes. And then as that happened and dialing in then the hormone replacement therapy, her transition was fantastic.
Great.
And she's still down 43 pounds now from where she had started and can't
Good job.
be happier, you know? So it is a transition that you have to treat all along the way.
In closing, I'm going to give you a 35-year-old female. She wants 3 things to do to keep herself vital and prepare herself from a 35 to a 50-year period. What do you tell her, Doc?
She's got to really, really work on resistance training. I know that when you approach exercise and you think of mobility and balance and cardio and muscles, 35-year-old female really wants to put energy into making sure that she's done everything she can to add muscle mass to the frame, because that is going to protect her from adverse outcomes and improve longevity. So along those lines, having a trainer that understands resistance training and progressive load training is really important to make muscles hypertrophy and be strong, make sure that they're well fed with the right kinds of proteins. We really like products that have a lot of leucine in them when we're looking for muscle hypertrophy. Making sure that, it might sound cliche, but I think 35-year-old women and men for that matter, they all start to kind of go off the cliff when it comes to sleep and sleep hygiene for different reasons. I think that making sure that they're doing everything they can to improve their sleep environment, very important. And also gut health going through your 30th decade into your 40s, and not just accepting bloating and constipation as the norm, but treating that appropriately, because the gut microbiome, while again, I think we're still in the infancy of understanding it, if it's healthy, I think the benefits for primary prevention 10 years, 20 years, 30 years down the road is going to really pay dividends for that person.
Outstanding. This is great. We hit our time. It was easy. The voyage was smooth. No potholes.
No hiccups.
Nothing. It was great.
I think I'd probably ditch the water as a supplement. It's not a supplement. Comment that I made.
But I agree with you.
But whatever you think is good by me.
No, definitely great. So everybody, we're having a little conversation here. I'm going to sign off. Dr. Rob Silverman, Proven Health Alternatives. Dr. Charles Cavo, thank you so much for your time.